Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 529 of our pharmacotherapy series, which majors in anxiety disorders. This case applies to patient LTV in part 528 of this pharmacotherapy series. The physician decides to treat LTV's generalized anxiety disorder with paroxetine for maintenance and a benzodiazepine for quick control of his anxiety during the first several weeks until the onset of paroxetine's anxiolytic effects. My first question to you reads: what factors are important in the selection of a particular benzodiazepine agent for LTV? Of the available benzodiazepines, none have demonstrated clear superior efficacy in the treatment of generalized anxiety disorder. However, certain agents have been used more extensively than others. Alprazolam, lorazepam, clonazepam, and diazepam have been successfully used in the treatment of generalized anxiety disorder. Because of similar overall anxiolytic efficacies of benzodiazepines, other factors must be considered when selecting one agent versus another. Benzodiazepines differ in their pharmacokinetic properties, and these are generally the main factors considered in drug selection. Benzodiazepines can be differentiated pharmacokinetically according to their elimination half-lives and their metabolism to active or inactive compounds. Diazepam, marketed as Valium, and chlordiazepocid, marketed as Librium, have half-lives between 10 and 40 hours, and are metabolized by hepatic oxidative pathways to the active metabolite desmethyldiazepam. The metabolite desmethyldiazepam has a long half-life, and chronic dosing of benzodiazepines that get converted to desmethyldiazepam can result in drug accumulation and prolonged clinical effects. This can be especially detrimental in the elderly, those with liver disease, persons taking other drugs interfering with benzodiazepine metabolism, or those who are poor metabolizers. Although long durations of action make once-daily dosing possible, small, divided daily doses are often used clinically to minimize side effects. The elimination half-life of clonazepam ranges from 20 to 50 hours, making once-daily dosing feasible. Alprazolam, marketed as Xanax, or Niravam, and lorazepam, marketed as Ativan, have intermediate half-lives of 10 to 20 hours, and oxazepam, marketed as Serax, has a short to intermediate half-life of 5 to 14 hours. Alprazolam, lorazepam, and oxazepam usually need to be taken on a 3 times a day to 4 times a day dosing schedule for sustained clinical effects, but an extended release preparation of alprazolam allows daily or twice daily dosing. Alprazolam extended release may be associated with fewer CNS side effects than the immediate release form because peak alprazolam blood levels are lower. Notably, lorazepam, temazepam, and oxazepam are free of active metabolites and are unlikely to accumulate with chronic administration. They are preferred over longer-acting agents in patients with liver disease and in the elderly. Unlike phase 1 oxidative metabolism, phase 2 glucuronidation processes, the pathway for these three agents do not appear to decline with age. Benzodiazepines are readily absorbed after oral administration. Lipid solubility varies among the agents, resulting in differences in rates of absorption and speed of onset, as well as duration of clinical effects. Diazepam and clorazepate have the highest lipid solubilities and the quickest onset of action, which can be desirable when rapid anxiolysis is needed. However, both can produce drugged or high feeling in some patients. Highly lipophilic benzodiazepines are also more quickly redistributed out of the brain, which decreases their duration of action acutely. Diazepam, lorazepam, clordiazepokid, and midazolam are also available for parenteral, that is intravenous and intramuscular administration for treatment of severe agitation or seizures, or for induction of preoperative sedation and anxiolysis. Intramuscular injection of both clordiazepokid and diazepam can be very painful. Lorazepam is the preferred agent when intramuscular dosing is needed for quick control of anxiety or agitation. Cost is another important factor in benzodiazepine selection. Brand name benzodiazepines can be relatively expensive, but all are available in less costly generic versions. Potential drug interactions should also be considered in the selection of an agent because they can alter pharmacokinetics and clinical effects. Because LTV is young and healthy and is not taking any other medications, the clinician could choose any benzodiazepine. A shorter-acting high-potency agent, such as lorazepam or alprazolam, would be a reasonable option for LTV. Appropriate starting doses would be lorazepam 0.5 to 1 mg thrice daily or alprazolam 0.25 to 0.5 mg thrice daily. Dosages can be increased every 3 to 4 days, if needed. LTV should notice a decrease in his anxiety symptoms within the first few days of treatment. Prescription of a generic formulation is recommended to reduce treatment costs. Alprazolam 0.25 mg thrice daily is prescribed for LTV in addition to Paroxetine. So my next question to you reads: what side effects may occur with benzodiazepine treatment, and how should LTV be counseled regarding benzodiazepine therapy? Overall, benzodiazepines are very safe and well tolerated. Sedation and feelings of tiredness are the most common side effects of benzodiazepines, but sedation can also be beneficial in alleviating insomnia that often accompanies anxiety. Tolerance usually develops to the sedative effects of benzodiazepines within 1 to 2 weeks of continued treatment. Consequently, benzodiazepine sedative hypnotics are recommended for only short-term use. Tolerance does not appear to develop to the anxiolytic or muscle relaxant effects of benzodiazepines. Benzodiazepines can cause cognitive impairment and anterograde amnesia, decreased memory for new information after taking the drug, which is dose-related and reversible on medication discontinuation. Tolerance often develops to the cognitive adverse effects, but they can also persist throughout therapy in some patients. Newer studies have demonstrated a possible association with long-term benzodiazepine use and dementia. Use of alcohol during benzodiazepine therapy greatly increases the risks for memory problems and sedation, as well as for other more dangerous effects, including respiratory depression. Elderly individuals are more sensitive to sedative, cognitive, and psychomotor effects of benzodiazepines, and tolerance to these effects may occur more slowly than in the non-elderly. Other psychomotor effects, such as problems with coordination and delayed reaction time, can also occur during benzodiazepine treatment. These effects are also dose-related, but usually subside within a few weeks of continued treatment. Long-acting benzodiazepines taken the previous night may cause residual daytime effects, which can result in car accidents and hospitalization in older individuals receiving these medications. The link between benzodiazepine use and falls, especially in the elderly, is well documented. Rapid dosage escalation and use of high doses have been identified as major risk factors, but even use of low doses of short-acting agents greatly increases the risk of falling in the elderly. Respiratory depression is another potential adverse effect of benzodiazepines, but it is usually clinically relevant only in patients with severe respiratory disease, in overdose situations, or when combined with alcohol or substances that depress breathing, like opioids. It is recommended that benzodiazepines be avoided in patients with sleep apnea. Respiratory complications are encountered most often with IV administration. Severe respiratory depression has also occurred with the concurrent use of benzodiazepines and olanzapine IM, marketed as Zyprexa, loxapine, marketed as Loxetin, or clozapine, marketed as Clozaril. Further, it should be noted benzodiazepines increase the risk of death in prescription drug overdoses, typically in combination with other medications or drugs of abuse. Paradoxical disinhibition, with increased anxiety, irritability, and agitation, can occur infrequently with benzodiazepines, primarily in elderly or developmentally disabled individuals. Other unusual behaviors, such as increased anger, hostility, depression, suicidal ideation, and rage, have been attributed to benzodiazepine use in a small number of cases. Most of these reports were anecdotal and involved patients with pre-existing psychiatric disorders such as bipolar disorder or schizophrenia. Overall, there is no convincing evidence that benzodiazepines actually cause violent or suicidal behaviors, but there is some evidence to the contrary. In summary, LTV should be told he may experience sedation and difficulties in thinking, concentration, or memory during the first week or so of therapy, but these side effects should resolve once he experiences some tolerance to the drug. He should be extremely careful while driving or performing other tasks requiring psychomotor skills, especially during the first week, and he should avoid the use of alcohol while he is taking benzodiazepines. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 530.